Good morning, everyone. Good morning and welcome back from coffee. I hope everyone's really enthused with the discussion this morning, as everyone's got their adrenaline going. We've got a great session coming up. I'm Vivek Mishra. I'm one of the oncologists at the Christie, and I'm going to be chairing this session. I think we've got some great speakers lined up here. So I won't keep you between you. I won't stand between you and them. I'll get my words right. So we're going to start off by introducing Dr. Amrita Talwalkar, who's the Director of Breast Screening and a consultant radiologist at South Lancashire Breast Screening Program. It's a very, very topical thing. If you've been following the news this morning, according to Elon Musk, none of us need to work in the future. AI will do everything, and we can work if we want to, just for self-satisfaction. So I'm sure Dr. Talwalkar will tell us how that will pan out.
So good morning, everyone, and thank you for this opportunity for letting me talk here. So as Vivek said, it's a very topical issue about artificial intelligence in breast screening. I don't think in my lifetime I'll be able to retire, but hopefully somewhere along the line, AI will come and help us. So breast imaging has always been at the forefront of embracing all this, incorporating advanced technological advances, and breast images have been connected to cutting-edge technology long before AI came into the picture. My talk today is going to be basically concentrated mainly on the mammographic screening aspect of AI, mostly because that is where most of the research and developments are taking place. I will briefly touch upon other modalities of imaging. So how did we start looking at machine learning? So on your right is the R2D2 of radiology. This is an R2 technology image checker, the M1000, which was sort of a device which was taught how to look for abnormalities on mammograms. On the left here, where my arrow is, areas of calcification, and this image checker was taught how to look for these little clusters of calcification and a mass. And it was what we call a CAD system, computer-aided detection software. It was sort of investigated in the 1950s and 60s in research papers, but then came into sort of commercial approval in 1998 by the FDA. It was meant to read a mammogram in 6 minutes at that point. And as I said, it was manually taught how to pick up focal clusters of calcification defined as more than 3 little dots of bright signal on the mammograms. But, I'm sorry. As they tried to implement this software into clinical practice, it was found that it had a lot of false positive results, and the radiologists didn't really sort of rely on the CAD imaging results for their diagnosis, and it slowly sort of phased out. So when was AI actually built into this main line? This came out with a DREAM challenge, which was introduced in the United States, where the primary benefit of this challenge was to establish new tools in deep machine learning for an impact into the breast screening towards more benefit and less harm. And they asked coders to come and participate to predict models to diagnose breast cancers in about 600 mammograms, which were sort of retrospectively given to them for analysis. And through this DREAM challenge, a lot of the current coders came out, and the companies that are out on the markets just now have built through this digital mammography challenge in the US. Across the road here, what is happening in 2020, the NHS AI Award was launched, which supported technologies which in support of the NHS long-term plan for health promotion and diagnosis and treatment. The plan was divided into 4 phases, which went from feasibility, development, clinical evaluation, and real-world testing. There were more than 123 million pounds available over a 4-year period, and a total of 86 awards were given. So this is just a big list of the people who won these awards. And on the left, where there was a phase 1 initiation, that is where one of the chemotherapy AI awards was given. And then on the right is our phase 4 award, which is the MIA Mammography Intelligent Assessment System by Chiron Technologies. And this was awarded for investigation of AI into breast screening. And this is what has been trialed across the UK at the moment. So does it work really? So up to that point, through all the commercial companies that came out, there were a lot of retrospective analysis which was done, and there were a lot of papers showing that in retrospective data sets it worked, and the accuracy was almost equal to a radiologist. But a lot of the criticism around these data sets was they were enriched data sets, which meant they weren't live prospective patients. They were retrospective collections of data which were given to the AI to analyze. And in that setting, it was proven to be as good as a radiologist. So on the back of that, there was a rapid review consultation by the government to look into the use of AI in breast screening. And they came out with the recommendations that at the present moment, there isn't enough evidence for us to use it in a screening setting, because most of the data is retrospective. There's no prospective evaluation. And they then called for high quality randomized prospective controlled trials to look into screening. So where are we up to in 2023? So this is a list of prospective trials and observational studies that are ongoing. I will mention the Masai study, which is complete. It's a prospective trial, randomized controlled trial in Sweden. Some of them are still ongoing, and some of these studies are complete. And we are hoping that by the end of this year, the data to all of these will be published for us to review. The bottom 3 are from the UK, and I'll go through these in a bit more detail. So this is the Libra study, which is been just about to start in Leeds. They actually tried to they started off at the end of last year, but it has taken them nearly 6 months to get NBSS, which is our screening software system, to talk to AI. So there's been a massive delay because of that. How does this study work? They are going to look at screen read mammograms, which are read by 2 film readers, and then the final result from that double reading is going to be randomized to an arm which will be read by the AI, and the second arm will be sent back to through the normal screening pathway. Where the patients who are read by the AI will then again be arbitrated depending on whether the AI has recalled the patient or not, and this is how they will compare both arms of the trial. Now, this trial has hit a lot of issues, partly because, as I said, we have a very archaic screening software called NBSS, which does not talk to any other software within the NHS. So they've just about started this for the first time. The soft launch has kicked off. The second study, which has been done in Scotland, called Gemini. Now, this was slightly different. Again, they have had technical issues, and they've just started their study. And what they are doing is they are letting the patient go through their normal screening pathway, and then the AI would reads all the mammograms once the screening pathway is complete, and they are just observing to see whether the AI picks up anything that the screen readers don't. They do plan to recall these patients if there is an obvious discrepancy found after the screening pathway is complete. What they've done in Scotland also is they've done a retrospective 3-year study, between 2016 and 2019 and got MIA, which was the AI software, to analyze all their mammograms. And there were some interesting things that have come out of this retrospective analysis. They found that every time the mammography software changed, the AI recall rates went up, which meant that more patients or more ladies were being recalled from screening back to assessment. And so every time that happened, they had to calibrate the threshold of the AI. And even with that, they have only been able to manage to bring that recall rate, which means the number of patients being called back from screening to an assessment clinic to 13%. The AI detected an equal number of cancers to normal film readers, that is 277 out of 303 cancers. Interestingly, it also picked up 47 of the 139 interval cancers that they had. So that is a benefit. It managed to pick up those 47 cancers which the screen readers had missed. So they've deducted from their study that there's a possible workload saving about 30 to 40% if they use AI. But at the present moment, the recall rate is quite high when compared to human readers. The third major retrospective study that is ongoing at the moment is the ARIES protocol. This is between North London and Gateshead, and they've been collecting data over the past 12 months for retrospectively. Their data collection is complete, looking at screening mammograms that have gone through their units, and we're waiting for the results to come out. Now, these are the sites in the UK that have had service evaluation. What this essentially means is that they have had MIA as a silent reader in the background, evaluating mammograms. There's been no impact on the screening work flow. So if a patient has standardized screening, their pathway does not get affected. They go through the normal recall and assessment. What then happens is that the AI reads these mammograms, and if it decides to call any of those patients back, they're then reviewed again by the film readers, and then if there is a necessity for recalling these patients, they are called back through the symptomatic service. So we've had some early results from this. There are 15 sites, and the reason I'm talking to you today is because we were one of the first sites in Wrightington, Wigan and Leigh, to use this software and trial it. So what have we found out from our early results? We've done about a 6-month review for the first half to just evaluate how accurate MIA is. So we found some results similar to Aberdeen, and there is a high recall rate. So our recall rate for the 6 months for human readers is 4%, while MIA's recall rate is 13%. It does have a very high negative predictive value equivalent to human readers. It is not better than human readers at this point, but its negative predictive value is equivalent to human readers, which means if it says something is benign, it is benign in nearly 97% of the cases. Its specificity is high, so sensitivity not so high. University Hospital Birmingham is the only trust in the UK who has actually brought this software, and their intention is to actually use this in a screening setting, provided they get approval from the National Screening Committee. So we are waiting, all of us are waiting to see what happens with their case. In addition to this, there have been some studies carried out around AI perceptions with regards to what patients and film readers think. And it's clear from the charts here that they were asked whether they would like AI to be in a triage capacity or as a reporting companion, reporting independently, or as a double reader. And I think the strongest evidence here is to say that most people would prefer it either in a triage capacity or as a reporting companion. A complete replacement is not really preferred by anyone, either the film readers, this is the analysis of the film readers, or patients. And this has been seen in other studies across Europe and America. So there are some ethical issues which have been discussed at all the meetings that I've been to, as to, especially by the radiologists, that if an AI picks up, misses a cancer, who is to blame? And I think that is something that is also been discussed at various meetings that we are having at this point. But this is something to consider. So what's happening elsewhere? This is the study that I was talking to you about at the beginning, the Masai study, where they have used a software called Transpera, similar to what we use MIA. And they've done a prospective study looking at cancer detection rates. And what they found is that the cancer detection rate by Transpera is almost equal or slightly higher than human readers. So on your left here is AI supported film reading, and this is standard double reading in their cohort of patients of 80,000 divided 40 and 40 in each group. The recall rates are similar to human readers, a positive predictive value slightly higher with the AI supported group, and no false positives. Another interesting thing, and I think this is the most interesting bit of AI, is predictive, what they call predictive AI, which there have been a few studies on this, but this is something that for the future. This mammograms on the left here was scored by AI. So in this study, 1,600 patients were given mammograms screen detected or interval breast cancers, and their previous mammograms were reviewed by AI. And you can here see that the AI has given it a risk score. So they were given a score from 1 to 10, and 10 was the highest risk. So this patient was given a risk score for the left breast here, and you can see that they've developed an interval cancer further along. So they found that 38% of screen detected and 39% of interval cancers had higher risk scores on the AI on the prior screening mammograms, and this might be something that will sort of gain momentum in risk stratification and dense breasts. I think this is where it will be useful. And imaging in other modalities, there have been very few studies on AI in ultrasound imaging, but there are only 2 pieces of software at the moment out there. The QV CAD and KAIOS software, which looks at static ultrasound images to detect abnormalities, and they've shown a good positive predictive values, but I think more studies are needed with regards to that. In addition to that, they have, we all know about the automated ultrasound systems, which GE are, they've got an Invenio automatic ultrasound system, and I think they pair with the 2 AI softwares to use for detection of abnormalities on ultrasound, but I think more studies are needed there. So where do we go from here? Following all the reviews by the National Screening Committee, there was a health technology assessment program which has put out an NIHI grant for prospective randomized controlled trials in AI in breast screening, and the deadline is mid-November, so I think that is where we are heading towards more prospective randomized controlled trials before we actually incorporate it into a screening scenario. Can we use AI in screening at the present moment? We can't. Is it ready from our experience to be used as a single reader or even as a second reader? It's not. So where does it stand? Where do we stand with it in the system at this point? From our perspective, from our experience, I think it could be used as a triage tool to try and triage patients who are obviously high risk and bring them for earlier recall. And I think we all have issues with us. Breast screening units have issues with staffing and film readers. So I think this is where it stands. AI should be used as a triage tool in those situations so that we don't delay our patients for assessment. it could be used in a assessment setting, again, just as an adjunct. It is not ready for a full independent reading capacity yet. Thank you.
Brilliant. Thank you very much for that. I think it is very topical, and I think we'll see increasingly how AI permeates everything that we do. So it's high time that we start having talks like this, and it might actually help your service as well. Actually, in the future, to work out whether nostalgia is associated with cancer or not. Who knows? There we go. So you don't need to give your talk then. Moving on. Thank you very much. We'll take questions at the end. So it's my pleasure to actually invite Mr. Gandhi. And I think it's going to be a bit of a double act as well. Claire Robinson, who's an advanced nurse practitioner at MFT. So you're both going to talk to us about the ASPIRE pathway and how that can be helpful in reducing the workload of breast units. Thank you.
Thank you. Thank you. So I was asked to talk about the best practice time pathway, the ASPIRE National Research Project, and evaluation nostalgia clinics. So let's get going. So we know that nostalgia will occur in up to 70% of women during their lifetime. We know that there's no association of breast pain with breast cancer. Of course, some women with breast pain will get breast cancer and will present with breast cancer, just like some women with gallstones will develop breast cancer, and some women with varicose veins will also develop breast cancer, because breast cancer, sadly, is fairly common. Out there, there is still a persistent concern amongst women, fair enough, and primary care, that there is a link between breast cancer and breast pain, nostalgia. And as a result, up to 20% of women in cancer clinics, one-stop clinics, actually present with nostalgia. So that is manifested in this slide, and this shows the referrals over the years. Yes. Okay, so it works on the wall, but not on the... All right. So you can see for all ages, except perhaps the very old, for all ages, breast clinic referrals are going up, up, up. We see that breast 2-week referral to cancer treatment times are going up. And in particular, I want to bring your attention to the grey histograms, which show the number of breaches of the 62-day referral to cancer treatment waiting time. You can see the breaches are going up and up. So that's not what we want. We don't want cancer patients waiting longer than they should. What do we do? What are the solutions? Well, around March 2020, for lots of reasons around that time, the ABS decided that actually telephone consultations should be considered for women presenting with nostalgia without any symptoms which suggest breast cancer. So if a woman has a breast lump and breast pain, that's not nostalgia, that's a lump. If she has nipple discharge and breast pain, that's not just nostalgia, it's nipple discharge. If she has just nostalgia, that's what we're talking about, patients with breast pain. Shortly after, GM Cancer fell in line with this. They accepted ABS advice and recommended services consider alternative pathways that could vary from the standard one-stop triple assessment. A few months later, NHS England kind of fell in as well. They said patients at low risk of breast cancer, including those with nostalgia, should be given digital information and educational resource around breast health as an alternative to the one-stop clinic. They sat on the fence a bit about imaging, and I understand that. So Bolton and Wythenshawe, perhaps others, I don't know, but I know Bolton and Wythenshawe were early adopters of this new suggestion. And we took this on, slightly different pathways, but we took this on, and we both realised that actually, if we're going to do this, we have to audit it, we have to monitor it, and we have to know what the outcomes are. And, well, the first outcome, and this is Bolton data, it's excellent data, it shows that Mastalgia referrals dropped from 20% down to 8.5%, with a huge amount of effort and energy that Bolton put into their service, or their Mastalgia service. We put similar efforts in, and we collected proms. And happily, our patients told us that they were very satisfied with the service, in particular because they saved time and it was convenient. And almost all of them would recommend the service to the family and friends. So this is very encouraging. So we put into the national, Katie and Claire put the project into the National Times Awards and won. So the Manchester Mastalgia Pathway won a national award. So congratulations to them. And I think their award was a giant mobile phone. Bit odd. Whilst all this is going on, of course, GM Cancer are also working in the background, putting a huge amount of thought into how can we help our local services. And after some discussions, there was unanimous support around GM Cancer for a region-wide, when I say region, I mean GM Cancer footprint, region-wide telephone Mastalgia clinic, either nurse-led or led by GPs with extended roles, or both, or some variation on that theme. And of course, they said, if we're going to do this, this is kind of new, we should do strict audit, we should collect data. And in particular, we should collect data on all women having mammography, because we want to see, is it really worth it? Should they have mammography? Now, there was a paper published last year showing that mammography was a bit of a waste of time. But I guess you can't go off one paper from one unit. So this region-wide, it'd be stronger data. So I really commend this bolt-on of research and audit onto a new development. So at the end of this audit, we'll know whether women over 40 should have routine mammography or not, or we'll know a lot more at least. So GM put together a package. They started, first of all, they fought for a lot of money, which they got. They then started to put a package together, recruiting GPs with extended roles into each breast unit, developing educational packages and support for the GPs. They put individual site visits into place to help each unit develop their telephone Mastalgia service. And at the time of writing these slides, 3 of 6 units had dedicated Mastalgia clinics. The remaining 3 were not far behind. And I'm going to ask Claire to just fill us up on the latest news on that. They are presenting all the updates to the local GM Pathway board and presenting them at national conferences, and they are publishing their updates as well. So this is all open and honest, putting it all out there. They put a huge amount of effort into this. And Claire, if you can just tell us where we're up to.
Yeah, there's nothing much more to add really to that. Thank you. So yeah, I'm really happy to say that 3 out of the units, 6 units have got on board with the Mastalgia Pathway and delivering it really successfully. We're not that far behind with the remaining 3 units. We've just got a little bit of tweaking to do in terms of research, triaging and getting that pathway embedded. But yeah, I think we're on track for that. Haven't really got anything else. We're getting the message out there. Miss Garnsey presented at the NHS Confed Expo early this year, so that's been sort of widely recognised, our pathway now, and we're regularly publishing in the primary care network bulletins, so we're sort of plugging the Mastalgia pathway wherever we can.
So this ties in nicely to the Association of Breast Surgery Aspire project. Now, there have been 2 new Mastalgia pathways published in peer-reviewed journals, the Manchester one and the East Midlands one. So they've been subject to peer review and publication, but we know there are far more than 2 variations on this theme out there across the UK. There are loads of them. And so which one is best? Which one is cheapest? Which one is most effective? That we don't know. So the ABS Aspire project is set up because, again, we recognise that this is a new development in breast care and we need to evaluate it, and we need to evaluate it rigorously. And that's where the Aspire project comes in. So they are going to gather data from all the breast pain service delivery models across the UK. And our GM model is going to interlock, and we're feeding our data into Aspire. And hopefully, most other regions are too. And the aim of Aspire is to evaluate these new pathways using an established evaluation design. And in particular, they're going to look at safety, of course, patient satisfaction, and use of resources. We have to look at use of resources. And the kind of streams that they'll be assessing are highlighted here. There's 1, 2, 3, 4, 5, 6, 7 different streams, all of which are important in assessing a new service. So I really do commend the Aspire project. If you've not heard of it, please speak to me or Katie or Claire. Katie's on the National Organising Committee, Katie Ellis. Now, whilst all this is going on, a completely unrelated but subsequently related movement is happening in NHS England. And that's the faster diagnosis pathway. We've all grown up with the 2-week pathway, the 31 days, the 62 days pathway, but I showed you on the slides earlier that we're failing those now, and we're not doing as well as we might. So NHS England said, right, we're going to scrap them, and we're going to have a new pathway. We're going to call it the faster diagnosis pathway. So we spent most of 2022 arguing over commas and full stops in this. It went to NHS England in June, and it's now been pushed around various desks since June. And I see a lot of wry smiles in the audience because I know you've all been there. So I don't know when this will be published. It might be next week, it might be next year. But anyway, it's coming. And what the group recognised, and NHS England have recognised, is that the pinch point is the overwhelming of the one-stop clinic. Because there's far too much demand and not enough capacity. And this best practice timed pathway, which is a different way of saying the faster diagnosis pathway, specifically addresses the pinch point by mandating triage. This is different. So in the past, everyone come in, we'll see you in 2 weeks. Now we're going to triage. Okay, so we're going to triage into a red stream, cancer suspected, and a green stream, cancer not suspected. And let me show you how it probably will work. So this is draft. As I say, still with NHS England. It'll probably look very much like this, but I can't guarantee that. So this is the red pathway, cancer suspected. This is at the point when the GP refers. The GP will make a decision, cancer suspected, cancer not suspected. So in this situation, the cancer is suspected, and the day naught is the day of receipt of the referral from a GP. Or, in screening patients, let me just read this right. The decision to recall in the NHS BSP. So, because the day you recall is the patient receives that letter is the day they start worrying, naturally. So that's day naught. So by the day 28, we should be saying to patients, you have got cancer, or you haven't got cancer. So there's got to be a binary, you have or you haven't. That's what we're supposed to say by 28 days. The threshold you have to meet is actually quite soft, 75%, which I think is way too soft, but I think it gives us some breathing space. But there's no doubt in my mind, because I've worked with these guys over the years, that in the future that'll creep up. It'll be 75, the next health secretary will say, oh, I'm better than the last health secretary, it's now 80, and so on and so on. But at the moment, if it comes out like it's supposed to come out, it's going to be 75% of patients have to be given, you have got cancer or you haven't got cancer by day 28. And you can read in the boxes how it all works. With regards to breast pain, we're obviously on the green pathway. Okay, so again, day 0 is the day of receipt of the referral, and they go through triage, and then they're dealt with in the appropriate clinic by the appropriate person who may be of any maybe any member of the breast healthcare team. It needn't be a consultant, it might be. And again, by day 28, they'll be told, you're fine, your breast pain is not cancer. Now, in my mind, this will be a relatively easy target. We'll probably tell 90% plus of green pathway patients by day 28 they haven't got breast cancer. And also, at triage, a green patient can be converted to red by whoever does the triage. So they can be referred as a green, there's some red flag signal on the letter, and the triage person can just immediately put them into a red pathway. And at any point in the green pathway, that can happen, which I think is really reassuring for us as a service, for us all as a service, and of course for patients too. Now, my last slide is next, and there are sometimes people who say, it's a green pathway, they've got gynecomastia, why do we need any standards? Why do we have to tell them by 28 days? Anything, we'll just do it in our own time. And I've got 2 answers to that. This is one answer. So this is proportion of patients seen within 14 days for breast symptoms, cancer not suspected, and it's going off the edge of a cliff. Okay? It used to be 95%, which is nice. It's the kind of service we want to work in. And it hit 55%. Not the kind of service that we dream of. My colleagues in Scotland tell an even worse story, where patients in the green pathway can wait up to 2 years for an appointment because the red pathway is always switched on to 11. So it's just crazy. And so we need a standard for the green pathway, because we don't want this, I don't want my unit drawing a graph like that, I'm sure you don't, and we don't want to offer the service that the poor Scottish women are getting on their green pathway. So that's why we need a standard for cancer not suspected. And that's my last slide, thanks.
Thank you, Ashu. I think that's a very insightful talk. I think it's not just talking about where we are now with regards to the nostalgia, as you said, we don't need AI, but also focusing on how things are bound to change to make things better for our patients, not just those who have cancer, but quite rightly those who are waiting to be told that they don't have cancer. And I think if any one of us has ever waited for a test result, you know how stressful that period is. So I think that's very good, very evocative, and I'm glad people are looking at that. Moving on to now, the bit that sort of excites us oncologists, but probably everyone else glazes over in the MDT when you start looking at cancer diagnosis patients, and there we are rattling out the name of all these IBS and ABS and so on and so forth that have just been licensed and made available. And I think it's important, this next talk, which is a double act. I think you're going to start, Suzanne Frank. You're, let me get your title right, Advanced Specialist Breast Cancer Pharmacist at the Christie, or as we like to call her, a person who does everything. So you're going to be talking about what's changed in early breast cancer, and that will then be followed by Dr. Anne Armstrong, medical oncologist from the Christie, about advanced breast cancers. And one of the things that I think is being highlighted in these couple of talks is the impact this has not just on the patients. Obviously, there'll be toxicity, etc., the positive impact on patient outcomes, but the impact it has on being able to provide sustainable oncology services in Greater Manchester. And I think hand over to Suzanne at this point.
Thanks, Vivek, and thanks everyone for having me here today. So, as Vivek has said, we're going to split this into early breast cancer and secondary breast cancer, and my plan is to focus on 3 agents that were NICE approved and consequently NHS funded for our patients in the last year or so. I'll explain which patients are eligible for these treatments, the top line efficacy data, so why we're using them, what toxicities we can expect to see, and what their place is in the treatment pathway. So I would hope everyone in the room knows that we decide how we treat breast cancer because we divide breast cancer into 4 subtypes, and the treatment decisions are made on the staging of the disease and that subtype. And I've highlighted where the new agents are available. So for the early breast cancer patients, it's in the hormone receptor positive, HER2 negative subtype, and in the triple negative subtype. So the first agent and the first word, the first mAb I'm going to talk about is pembrolizumab, and this is a type of immunotherapy. Now, immunotherapy has been around and embedded in treatment for other cancer types, such as lung cancer and melanoma, for quite a long time now, a number of years, but it's still relatively new in the field of breast cancer. And pembrolizumab, I'll try and give you a bit of science, and it is a bit complicated, but it basically works by disabling the mechanisms that the cancer cells use to hide from our immune systems. So it does this by binding to a PD-1 receptor on T cells, which is part of our own immunity, and it prevents interaction with PD-L1 and PD-L2 binding ligands on the tumour cell surface. So basically, it effectively disables the off switch and enables our patient's own immune systems to then attack that cancer cell. So it's given prior to surgery, intravenously, every 3 weeks, and initially it's given in combination with chemotherapy. And this is fairly punchy chemotherapy. So it's paclitaxel and carboplatin, given weekly for 12 weeks, and then epirubicin and cyclophosphamide, given 3 weekly for another 12 weeks. Patients then go off, have their surgery, and then they come back. If they need radiotherapy, the majority of these patients will, they have their radiotherapy, and then they get more pembrolizumab. So they then get it as monotherapy, and we then give it 6 weekly, every 6 weeks for another 7 months or so. So it's a long treatment pathway for these patients. This was NICE approved last December and is available to patients with triple negative early breast cancer with an invasive tumour size of greater than 2 centimetres, or patients with smaller tumours if they've got lymph node involvement. And as I mentioned, it's pretty tough going, this chemotherapy regime, so it's not suitable for those patients with a poorer performance status or a lot of comorbidities. So this is the Keynote 522 study design on which that NICE approval and the product licence was based. And this was a phase 3 trial of over 700 patients with early triple-negative breast cancer who were randomised to receive pembrolizumab or placebo in combination with their chemotherapy, which was 8 cycles of the PCEC chemotherapy, followed by surgery, and then either further placebo or further pembrolizumab after their surgery. And this trial demonstrated an increased pathological complete response of 64.8% versus 51%, with an event-free survival rate, which is a composite measure of overall survival and invasive disease-free survival, of 84% versus 76% at 3 years of follow-up. There was a benefit in survival for those patients who had residual disease after their neoadjuvant component, as well as the patients who had a pathological complete response. And interestingly, unlike metastatic breast cancer, which Anne will be telling you about, the benefit of the immunotherapy in early breast cancer isn't restricted to those patients who overexpress the PD-L1 receptor, which is why I gave you that bit of science at the start. So even patients who don't overexpress PD-L1 seem to benefit from pembrolizumab in early breast cancer. And that's very different to the metastatic setting, which Anne will tell you about later. So in the neoadjuvant treatment phase, the incident of treatment-related adverse events at grade 3 or above, so those more serious adverse events that we're worried about, was 77% in the pembrolizumab and chemotherapy arm and 72% in the placebo chemotherapy arm. It did include some patient deaths, but they were equal across the two arms. And we can see that more patients in the pembrolizumab arm discontinued treatment because of adverse events than in the chemotherapy-only arm. So lovely. So yeah, we're used to managing predictable toxicities from chemotherapy. So we know that patients are likely to feel pretty lousy in a few days after they've had chemotherapy. They get nausea and vomiting, they feel tired, they get GI disturbance, they lose their hair, they get mucositis. We know that they're likely to get neutropenic. We know when that's likely to happen. We're very used to managing those side effects. But the immunotherapy agents have a lot of weird and wonderful toxicities that we are having to get to grips with. So basically, we're trying to enable the patient's immunity to attack the cancer cells, but sometimes the body gets a bit confused and starts attacking the body's own cells and the body's own normal cells. So the most common immunotherapy-associated toxicities that we see are things like rashes and colitis, which manifests as diarrhea. And sometimes we can manage that with fairly conservative management, symptom relief, oral steroids, but it can be quite serious and it can need IV steroids. It can need infliximab. It can need immunosuppressants, things like mycophenolate. And some of our patients have actually been admitted to ICU with the toxicities from this regime. We've seen pneumonitis, hepatitis, nephritis, myocarditis. If there's an itis, they can get it, basically. And we see endocrinopathies. And patients who are rendered diabetic or hypothyroid by this drug are likely to remain diabetic or hypothyroid even after the drug is stopped. So we're on quite a steep learning curve, and we're needing quite a lot of input from our acute oncology teams and other multidisciplinary teams to help manage the side effects that these patients are seeing. Now, this is an example of the patient pathway leaflets that Dr. Alice Lewis, who spoke to you earlier, has helped us develop to try and help us navigate our patients through their individual treatment pathways. This is the one for patients undergoing neoadjuvant treatment who've got early triple-negative breast cancer, and I've highlighted where the pembrolizumab falls. So they get it prior to surgery with their chemotherapy, and then post-surgery. We actually need to move this box down a little bit because we actually start pembrolizumab adjuvantly about 2 weeks after their radiotherapy, because our clinical oncology colleagues have asked us not to give the two together. Certain drugs can be radiosensitizers. They can make the side effects of radiotherapy worse. So we prefer to give it after the radiotherapy has completed. And our local experience with pembrolizumab, so once NICE made a positive technology appraisal, even though the NICE publication is a little bit later, the drug is immediately made available through the Cancer Drugs Fund, and that was a little over a year ago for us. It was the start of October last year. And since October last year, we've initiated 103 patients on this treatment. It's placed an increased strain on our SAC services because before, this type of patient would be having 6 cycles of chemotherapy. They're now having 8 cycles of chemotherapy. They've then got that extra 6 months when we wouldn't normally have given them any extended adjuvant treatment after surgery. And we are treating patients on that monotherapy part of the pathway through our Christie at Home service. So they're getting their pembrolizumab when they're on the monotherapy in their own homes. And that's to try and improve capacity in our chemotherapy units. And we're also seeing an awful lot more toxicity. So the different toxicities, but also it's a tough chemotherapy regime, so it's associated with its own toxicity just from the chemotherapy. So the second drug I want to tell you about is olaparib, and this is a PARP inhibitor that's available for the adjuvant treatment of our patients with HER2-negative tumours who are known to have germline BRCA mutations. So BRCA mutation-positive tumours have quite a unique molecular biology, and that makes them susceptible to PARP inhibition. So as the tumour cells proliferate, they accumulate DNA damage. And the tumour cells survive because they repair that DNA damage using the PARP enzyme. If we knock out that enzyme, they can't repair that DNA damage, and it means they're more likely to die as they proliferate. So the availability of this agent now means that it's really, really important that all those patients who meet the R208 genetic testing criteria are appropriately screened, so we know who our patients are who have these BRCA mutations. And interestingly, if patients don't meet the R208 genetic testing criteria, but they would be otherwise eligible for olaparib if they had a BRCA mutation, the R44 test has been added to the National Genomic Test Directory, so we can also screen those patients to see if they've got a BRCA mutation. It's an oral agent. It's taken twice a day for 12 months. And for hormone receptor positive patients, it's taken in combination with their endocrine therapy. Some patients, by default, will meet the criteria for olaparib and pembrolizumab, so they'll have BRCA mutation and triple-negative breast cancer. Some patients will meet the criteria for olaparib and abemaciclib that I'm about to speak about next. But in the NHS, we're only allowed to use one of those agents. We're not allowed to use them concurrently, and we're not allowed to use them sequentially. So we generally favour olaparib if patients have known BRCA mutations. So this is the eligibility criteria for adjuvant treatment with olaparib. It's divided into whether patients are triple negative or hormone receptor positive, and then it's further stratified by whether or not they underwent neoadjuvant chemotherapy or adjuvant chemotherapy. And the criteria are slightly different depending on which category the patients fall into. And the Olympia trial was the trial that provided us with the evidence of benefit for olaparib, which was a phase 3 trial of over 1,800 patients who were randomised to receive either extended adjuvant treatment with olaparib or placebo, and the primary endpoint of that trial was invasive disease-free survival. So the 3-year invasive disease-free survival is 85.9% with olaparib and 77.1% with placebo, which is a statistically significant hazard ratio of 0.58. And the overall survival at 4 years was 89.8% with olaparib and 86.4% with placebo. Again, a statistically significant hazard ratio of 0.56 and an absolute risk reduction of 3.4%. So this is an adjuvant trial, but we've already got overall survival benefit data. And this is the toxicities that we see with olaparib. So it's generally pretty well tolerated. Most of the events, so over 70% of adverse events, are grade 1 or 2. The most common toxicities that we see at grade 3, which is the darker purple bars, are anemia and myelosuppression. And this is where we would use it in our triple-negative breast cancer patient population who've undergone neoadjuvant SACT. So if they are confirmed to have a BRCA mutation and they haven't had a pathological complete response from their neoadjuvant chemotherapy, then they can start adjuvant olaparib. Again, we need to push this down a little bit because it would start after their radiotherapy. And we would probably favour adjuvant olaparib if they've got a BRCA mutation over adjuvant pembrolizumab. So they might have had neoadjuvant pembrolizumab, but we've got to decide between these two drugs, and we'd probably go for the olaparib at that point. Can also be used if our triple-negative patients have not had neoadjuvant chemotherapy, if they've had adjuvant chemotherapy, and if they've got BRCA mutation and an invasive disease, an invasive tumour greater than 2 centimetres, or smaller tumours with lymph node involvement, we can give them adjuvant olaparib. And for our hormone receptor positive patients, we can also use olaparib if they've got confirmed germline BRCA mutation, and if they've had neoadjuvant chemotherapy with 4 or more positive lymph nodes for adjuvant chemotherapy. And there's a scoring system based on clinical and pathological staging if they had neoadjuvant chemotherapy, which is a little bit complicated, but you can kind of work through that on one of the previous slides. So we actually had access to olaparib before the NICE approval was granted on an expanded access programme. We treated 14 patients over the course of about a year, and then since the NICE approval in April of this year, we've initiated 4 more patients on treatment. So it's small patient numbers, but it's an important benefit for those patients. And the last drug I want to tell you about is abemaciclib. And this is another oral agent. It's known as the CDK4/6 inhibitor, and it's taken alongside either an aromatase inhibitor or tamoxifen for 2 years, and then the endocrine therapy continues beyond that, in patients with hormone receptor positive, HER2 negative, early breast cancer that is defined as being at high risk of recurrence. And for abemaciclib, that's defined as patients with 4 or more positive lymph nodes, or if they've got 1 to 3 positive lymph nodes and a tumour size of greater than 5 centimetres, or a grade 3 tumour, or they might have 5 centimetres and a grade 3 tumour, but if they've got 1 to 3 nodes and one of those features, they are eligible. Now, we've been using these drugs in metastatic breast cancer, CDK4/6 inhibitors, for over 5 years now, but this is the first one that's been licensed in early breast cancer and was NICE approved in summer of 2022. So we know that hormone receptor positive, HER2 negative breast cancer accounts for about 2/3 of breast cancers, so this is the drug that's had the biggest impact on our services. Around 30% of patients relapse despite treatment with surgery, chemotherapy, adjuvant endocrine therapy, and the risk of recurrence is highest within that first 3 years for those patients at high risk of recurrence. So Monarchy was a phase 3 open label trial of over 5,000 patients who were randomised to receive abemaciclib in combination with their endocrine therapy or their endocrine therapy alone. There was a second cohort in Monarchy that involved patients who were deemed as high risk based on the Ki-67 proliferation score. They represented, they're down here, they're cohort 2, they were only 9% of the patient total population. And the UK licence and NICE approval is based on cohort 1, so we don't use Ki-67 as a marker for eligibility for this drug. So the absolute difference in invasive disease-free survival seen with this drug is 6.9%, so it's 85.5% with abemaciclib, compared with 76.8% in the control arm, with a statistically significant hazard ratio of 0.65 at 4 years of follow-up. And this benefit is continuing to improve. So you can see these curves are continuing to separate as the data matures, even though these patients have all now completed their 2 years of treatment. And it's likely that these curves may well continue to separate as the data matures. At 4 years of follow-up, we also see an absolute benefit in distant disease-free survival with a magnitude of 6.1% of an absolute risk reduction. And again, these curves are continuing to separate. We haven't yet seen an overall survival benefit, but that data takes a long time to get for these big adjuvant trials. So watch this space. We'll just continue to wait and see as the data matures. So the predominant toxicity that we get with abemaciclib is diarrhea. We need to tell patients about it. About 80% of patients will get some form of GI upset with this drug. So we tell them about it when we consent them to treatment, we provide them with loperamide, and we dose reduce as necessary to manage this toxicity. We also see fatigue and myelosuppression. But an interesting observation from the Monarchy trial is that in the patients on the combination arm, there was a reduction in reporting of the endocrine-associated side effects, so the arthralgia and the hot flushes. We haven't yet worked out whether that's because they're more preoccupied with the fact that they've got diarrhea or they actually don't have hot flushes and arthralgia. But it is an interesting observation. And this is where abemaciclib fits into our treatment pathway. So the majority of these patients will have adjuvant chemotherapy. A few might have neoadjuvant chemotherapy. However, it would still fall in the adjuvant setting after they've undergone their chemotherapy, their radiotherapy, any subsequent surgery, and then they continue it for 2 years alongside their endocrine therapy. So in terms of local experience with abemaciclib, we didn't have the capacity to absorb this into our existing oncology clinics. It's a lot of patients. So we've set up a centralised abemaciclib service at the Christie to serve all the patients across Greater Manchester and Cheshire. It's quite an innovative service. We're using electronic patient-reported outcomes to monitor patient toxicity, and Sasha Howell is here later talking on that very subject. It's run with non-prescribing nurses, it's run with non-medical prescribing pharmacists, and oversight from a medical oncology consultant and a clinical oncology consultant to provide that medical oversight. We launched the service on Halloween last year, and by now over 200 patients have started this treatment, with around about a 90% uptake of eligible patients, which was more than we were expecting and certainly more than we modelled for. And the discontinuation rate so far, due to toxicity and unfortunately recurrent disease, is about 10%. We're only 1 year in. We might see some more drop-offs for the second year. So in summary, in the last 12 months, we got 3 new drugs in the early breast cancer setting. So far, over 300 patients have been initiated on these new treatments. All of these patients are now on extended adjuvant treatment pathways. They would otherwise have been discharged from oncology services back to surgical surveillance. And we're managing them through initiatives like our Christie at Home service and nurse and pharmacist-led clinics. Thank you. I'm going to hand over to Anne to tell you what's been happening at Stafford.
All right, so hi, my name's Anne Armstrong. I'm a medical oncologist. I work at the Christie, for those of you who don't know me. So I'm going to talk about the new drug treatments that we are starting to use for patients with secondary breast cancer. So many moons ago, when I started off as a medical oncologist, in hindsight, treatment of metastatic disease now seems quite easy. We had sequential single-agent chemotherapy for everybody. It was preceded by endocrine therapy for the ER-positive cohort and given alongside one course of Herceptin for the HER2-positive patients. The pathways are now a lot more complicated in a similar way to the early breast cancer pathways being a lot more complicated than they were. So, what's new in ER-positive metastatic breast cancer? So these treatment protocols are taken from the ESMO guidelines, and in the UK we mostly follow those, although we don't have access to some of the approved European drugs as yet in the UK. Our first-line management for ER-positive metastatic disease has not changed. We use endocrine therapy alongside a 4/6 inhibitor. We are moving away from using palbociclib and use more abemaciclib and ribociclib these days because of the better long-term data of those 2 drugs. The new agent that we've got here is a second-line agent. And this is called alpelisib. And apologies to Novartis for the spelling mistake of their drug on this slide. The SOLAR-1 trial randomised patients who had progressed on an aromatase inhibitor and who had got metastatic hormone-positive breast cancer. And the patients were randomised either to fulvestrant alone, which is another endocrine therapy, or to fulvestrant given in combination with alpelisib. Alpelisib is a PI3 kinase inhibitor. The trial included both patients with cancers who had PI3 kinase mutations and who didn't have PI3 kinase mutations. And the results showed that for patients whose cancers had mutations in the PI3 kinase pathway, they had a progression-free and overall survival benefit from the combination treatment. On average, they lived about 8 months longer. The patients who didn't have PI3 kinase mutations identified in their cancer showed no benefit from the treatment. The combination treatment is, however, a lot more toxic than fulvestrant alone. Fulvestrant alone has very few side effects. 70% of patients required dose reductions and 1 in 4 patients stopped treatment. Side effects include rashes, GI toxicity, but one of the other issues is that the patients can get problems with hypoglycemia. They all need to go home with diabetic monitoring kits, and sometimes we need to get the diabetic teams involved to help manage the patients. The other addition to the workload for the whole pathway is really that we need to screen these patients for their cancers for the presence of PI3 kinase mutations, which is a fair amount of additional paperwork for everybody and work for the pathologists. It's about one in 3 patients with metastatic ER-positive cancer will have a PI3 kinase mutation. Okay, and then moving on to HER2-positive cancer. these circles have shifted slightly. So the first line treatment of HER2-positive metastatic breast cancer remains unchanged. We use a taxane in combination with pertuzumab and Herceptin. And then we've got 2 new agents in second line and beyond. So the first drug is called trastuzumab deruxtecan. It's called Enhertu, all right? And this is an antibody-drug conjugate, like Kadcyla, but it's got a different chemotherapy payload. It's a topoisomerase inhibitor that's tagged on to that Herceptin molecule. And the DESTINY-Breast03 trial randomized patients who had progressed on first-line HER2-targeted treatment and who had previously received a taxane to either the standard of care, which was Kadcyla, or to Enhertu. And the results showed a significant benefit for the new agent. The latest data on the progression-free survival is an improvement from 7 months with Kadcyla to 28 months with Enhertu. It reduces the risk of dying by about 30%, but the median overall survival for both treatment arms has not yet been reached in follow-up. The drug has more side effects. So there's more side effects for patients acutely on treatment, so you get more neutropenia, more nausea and vomiting, more diarrhea. But the biggest issue and the worry with the drug is that it has a risk of causing interstitial lung disease. And it occurs in around 10% of patients who are treated. And if it's not managed appropriately, this is a potentially fatal complication of the drug. It can also cause long-term fibrosis, so patients who, if you get lung fibrosis, you get chronic symptoms. Interstitial lung disease symptoms are very non-specific. The patients get a cough, they get some breathlessness, but loads of other things cause that as well. Patients who go on the drug are warned to let the patients involved in their care know if they get a cough or breathlessness. And they are told to present acutely if they have these symptoms. But even when they present acutely, it's not always easy to diagnose interstitial lung disease because even the imaging changes can be caused by other issues like infections and so on. It also creates a lot more work for everybody within the pathway. So the patients who have any symptoms, we need to do a CT scan of their thorax before we redose them. And often those scans, the radiologist won't be able to tell us for certain whether they've got interstitial lung disease or not. A lot of patients, we're very fortunate we have a good interstitial lung disease team over at Wythenshawe, but we're slightly swamping them with queries about these patients because we want to be able to manage the patients and allow them to continue on the treatment where possible without risking a fatal complication. The drug is good, but it has issues. And then the next treatment that we have for HER2 patients is tucatinib. So tucatinib is an oral tyrosine kinase inhibitor. It inhibits the HER2 pathway, so the same pathway that trastuzumab and pertuzumab affect, but this is an oral treatment. The HER2 CLIMB study randomized patients who had progressed on second-line treatment with Kadcyla to either Herceptin and capecitabine or Herceptin, capecitabine and tucatinib. There was an improvement in progression-free and overall survival with the triplet therapy. Again, you don't get these gains for nothing. The drugs have additional toxicities. Tucatinib and capecitabine really have very similar toxicities, so they can cause skin toxicities, diarrhea. So for patients, we kind of multiply up the side effects, so they need to be monitored and managed. The drugs can also cause, so tucatinib, well, both tucatinib and capecitabine can cause liver abnormalities, and it's often challenging for oncologists to work out whether patients' liver function tests are getting worse because their cancer is progressing or because of one of the drug treatments. And then moving on to triple-negative breast cancer. The first-line treatment of metastatic triple-negative breast cancer is unchanged. Patients with PD-L1 positive metastatic triple-negative breast cancer are treated with immunotherapy, so either atezolizumab or pembrolizumab alongside chemotherapy. And for patients whose cancers don't express PD-L1, treated with chemotherapy alone. And then we now have a new second-line agent in the form of sacituzumab. So sacituzumab is another antibody-drug conjugate. This time the antibody is to TROP2, which is overexpressed on lots of cancer cells. And it's got an irinotecan type chemotherapy drug tagged onto it. The ASCENT trial randomized patients with metastatic triple-negative breast cancer to either standard chemotherapy of their physician's choice or to sacituzumab. And this again showed an improvement in progression-free and overall survival for these patients. The benefits were much more modest than with treatment with Enhertu, with an improvement in overall survival of about 5 months. But this is a much harder patient cohort to treat, and they do have a much worse prognosis. The drug has more side effects, so diarrhea, febrile neutropenia, and so on. And interestingly for this agent, the expression of TROP2 on the cancers didn't appear to correlate with response. And then, if we haven't got enough things to do, we've now got a new subclassification of breast cancer. So this is HER2 low. So HER2 low is a new concept, really, and I think it's not been fully... there are still discussions around what is a HER2 low cancer, but essentially this study randomized patients who had cancers that expressed some HER2, but not enough to call them HER2 amplified, so somewhere between 0 and 3+ or 2+ FISH amplified. The patients were treated with Enhertu, so the same drug that we talked about previously, and they were randomized between Enhertu and treatment of physician's choice. This showed improved progression-free survival and overall survival in both cancers that were HER2 low and ER positive or HER2 low and ER negative, although the vast majority of patients in the study, because it's more common, were the ER positive cohorts. This treatment is now going through NICE. It's approved within Europe. It got rejected on the first round of NICE, but they're going through the processes still. This is a lot of patients if this gets approved. There was a study that presented at ASCO this year that suggested if you biopsied the patients enough times, everybody was HER2 positive because you find a little bit of HER2 staining somewhere. So this it has the potential to add to our workload, the radiologist workload, the ILD team's workload. All right, and then I've just got 2 more things to say. First of all, more of these drugs are now have biomarkers of response. The ESMO guidelines suggest that patients with newly diagnosed metastatic breast cancer need upfront testing for these biomarkers. And I think we need to get slicker at this. So for patients who are triple negative, they need PD-L1 testing. Patients who are ER positive at the moment, we need to do that PIK3CA testing up front. The processes we've got in place at the moment are quite cumbersome and slow, and certainly lots of our triple negative patients are being started on chemotherapy in the absence of PD-L1 testing, which is probably not the optimal way to do it. And I think we do need, as a community, we need to work on better routes to get more efficient testing. And then this goes back to what Suzanne was saying. These drugs are great because they improve patients' outcomes, but they all have more side effects and they need more monitoring on. And so there is massive resource implications to the oncology workforce. This is a back of a fact packet planning that we did around patient numbers for these new drugs, and with the sort of 8 drugs that got approved in the last 12 months or so, we across Greater Manchester need about 8,700 new patient clinic appointments that we don't currently have in existence. So this is a lot of work. And we've already underestimated with the abemaciclib. We did quite a lot of careful monitoring for the abemaciclib, but we've already shown that we were wrong by about 30%. So on that cheerful note, I will finish.
Thank you very much. I think that was quite enlightening, and I think all of you can understand the pain that we all feel in clinics. We are running a bit over time, but I think it was well worth listening to those talks. I think we've got time for one question, I'm told. So any burning question from anybody in the audience? There we go.
Hi. No doubt everybody in the room will know, obviously, we've got these great treatments that can go on for a very, very long time. But as a CNS, what I see is the psychological impact of these long-term treatments that we're giving patients, and how are we supporting these in these clinics? Because obviously you've got 8,000 odd new patient clinics, but the impact is on scale. We've got patients at Leighton that are just really, really, really struggling. They think they finished at a year and it's going on for 2, 3, 4 years. How do you manage that in your clinic, Suzanne?
I don't think we do particularly well. I think the difficulty as some of these extended adjuvant treatments has landed is with those patients who had been explained their treatment pathway before these treatments were available. And it's been more difficult to explain, yes, you thought you were done and you've arranged this amazing holiday, and actually I want you to stay on treatment for 2 years. And we had some patients who decided that actually, I'll just shout. We had some patients who decided that they didn't want treatment on that basis, and we probably have more patients who actually decline treatment early doors. It's so much easier if they're expecting that pathway, which is why it's so great that you guys are all here today. A lot of people from surgical pathways, even if you can just drop a name in and give an idea of duration, it really, really helps manage expectations, and therefore helps manage the psychology of how long this is going to be. But you're right, we don't have enough nurses, we don't have enough support, and that is a problem absolutely across the patch, and I don't have the easy answer to that.
Excellent. I think that was a very good question. I think we'll close on that, but just on 2 points on that. One is that those pathways which Suzanne had shown, I think they're going to go through the GM Cancer Alliance approval process, so they should be available hopefully on the website. And I think it's very important, that point, that patients knowing that right from the beginning makes a difference. The second thing is a big plea to look at breast care nurses, specialist breast care nurses, who quite often are based in surgical units, as having a role in oncology management of patients as well. And there needs to be investment into breast care nurses, not just for early sort of surgery and then late metastatic, but also that in between, the adjuvant oncology pathway. Anyway, I'm not going to stop you from lunch. I've been told to remind you that you need to make your way out of here to have your lunch. There's some vegetarian option as well. But if you have any dietary requirements, please could you let the GM Cancer team know, or the staff there. And please could we be back by 1:45. Thank you. Have a good afternoon.